So this is going to be a 54-year-old man with intermittent epigastric pain over the last few months. He notices that it usually occurs after eating, sometimes has a metallic taste in his mouth, and he also notes that he has been coughing at night and it gets worse when he lays down. So he's given medication that helps him with his symptoms. What is the mechanism of action of this medication? So is it sodium potassium ATPase inhibitors, inhibition of calcium channels, hydrogen potassium ATPase inhibitors, or increased opening frequency of chloride channels? So I'll let you answer and then I'll explain. Okay, so the answer is going to be C. So it's hydrogen potassium ATPase. So first of all, this patient's diagnosis is going to be GERD. So it's going to be gastroesophageal reflux disease. Now, why is that? Well, they give you a few hints, right? So first of all, he has intermittent epigastric pain. So if someone has, for example, they can present with this, they can point at their abdomen, but also if they complain of chest pain, this should also be on your differential, especially if it's a burning type of chest pain. Now, they didn't mention that in this question, whereas in other questions, they might hint at it by saying it's a burning type of chest pain. But in this question, they're saying intermittent epigastric pain. But both of those are going to be similar and associated with GERD. The next thing is going to be that it occurs after eating. Now, this is, once again, leading towards GERD, because GERD is a problem with the lower esophageal sphincter, and when that gets loose, when it's not sealing properly, just like a valve doesn't seal properly, the acid in your stomach can reflux into it. And so obviously that's not good because the lower part of your esophagus wasn't meant to deal with acid on a constant basis. So it starts getting inflamed and it can actually go all the way up into your throat, and you can also experience that metallic taste that they reference here. This also refers to the coughing at night. So this acid can go up, it can go up high enough that it can actually trigger the cough reflex. And that's why it's also worse when the patient lays down, because especially if the patient is obese or if they're overweight, this can all stretch that lower esophageal sphincter and then cause the acid to come up easier. And so especially when you lay down, gravity's not helping you as much, so that acid has an inclination to go and trigger the cough reflex. So that's why if someone comes in with a cough, you also have to keep GERD on your differential, just because it might not be a pneumonia, it might not be COPD, it could be GERD. So it's always a good thing to keep on your differential for people with chest pain and people with cough. So those two things. Now, if you notice, the question didn't actually ask for either of those because it didn't ask for the diagnosis. It actually assumes that you know it and then knows that you give them medication. And not only the medication, but you have to know the mechanism of action. So the mechanism of action is going to be of the medication that can treat it is a PPI, so proton pump inhibitor, and that the mechanism of that is going to be the hydrogen potassium ATPase inhibitor. So let's talk a little bit about the mechanism of action a little bit more. So you have parietal cells, which are a specific type of cells in your stomach, and on the parietal cells you have the hydrogen potassium ATPase. But going back a little bit even further, you have something that stimulates it, which is histamine. So histamine goes onto the H2 receptor, the histamine 2 receptor on the parietal cell, and then triggers the hydrogen potassium ATPase to start working. So then it's going to exchange one potassium inside, and then it's going to excrete one hydrogen proton. So in this case, you could theoretically treat with cimetidine, even though proton pump inhibitors are more efficacious, but you could treat it with this because this stops it upstream. And this is more direct. It goes straight to the source of the ATPase and stops it. Whereas this is just going upstream and blocks it up here. It blocks it at this histamine receptor, and so it doesn't let it get to this point, whereas this blocks the pump directly. So they didn't actually give the choice of this. For that one, they would have the mechanism of action of a H2 receptor blocker, but they didn't give that. And so now just to review a little bit of general chemistry, so this is essentially a Bronsted acid, which is a definition of an acid that donates a proton, and that's what we have here. And so that's how this proton being donated and the accumulation of protons is the accumulation of acid, specifically hydrochloric acid, in your stomach. And then once again, for general chemistry enthusiasts, for the Ka, which is the acid dissociation constant, you essentially have this concentration going up as the hydrogen's increasing in the lumen. So this part's going to go up. And since this goes up, the overall number goes up. And so that's why the bigger the Ka, the bigger the acid dissociation constant, the stronger the acid. And that's why there's so much of this that you have such a strong acid in your stomach. And that helps digest amino acids, proteins into amino acids, and then it helps have that very low pH. And so now talking about the other medications and the other mechanisms of action. So we had one of the other ones, which was to decrease calcium channels. So it essentially inhibits calcium channels. So right here, so B. So if we go down, so an example of this would be gabapentin. And so gabapentin decreases calcium channels, and then this is typically used for seizure control or for neuropathic pain, especially for patients with diabetes. You can use this for neuropathies. And so next is going to be benzodiazepines. And so going back to organic chemistry, just to integrate all of our knowledge together from college and medical school. So benzodiazepines actually get their name from benzene, which is just a hydrocarbon. So it's going to be this ring, and it's going to be a diazepine, which is this ring with two nitrogens. So this core structure is actually where benzodiazepines get their name, and they're mainly used for anxiolytic purposes. So that just means that you're trying to reduce anxiety in the patient. And they're typically short-term in duration because people worry about the long-term effects of these, just because you're more likely to get addicted to them, and you have a higher potential for abuse of these medications. And so this one correlates with, back up here, with the increased opening frequency of chloride channels. So that's going to be benzodiazepines. And so for A is actually going to be digoxin. So for that one, we have the sodium potassium ATPase inhibitor. And so this is obviously not related to GERD, but this is the mechanism of action of that answer choice. And so digoxin is used for cardiac purposes. But it's not that used just because it has a lot of toxicities and side effects. So in general, to answer this question, you really needed to figure out the diagnosis first of all. And so they give you a few hints, and I give you a few variations of that. They could make it chest pain, a burning chest pain specifically, but the overlap would be the coughing at night, the worsening when laying down, and also worse after eating, and the metallic taste. So all these point to GERD. And then finally, that's a given. And then on top of that, you had to know what type of medication that they would give. And that would be either proton pump inhibitors or histamine 2 receptor blockers. And finally, you have to know the mechanism of action. And so that's why you look through these, and the only one that shows up here is going to be C. And like we covered, this is going to be digoxin, so it's not relevant. Inhibition of calcium channels is going to be gabapentin. And then finally, increased opening frequency of chloride channels is going to be benzodiazepines. So I hope that helped, and thanks for watching.